recorded. So it is being recorded. So that's the good news. You can reference it later, and then you'll also have the opportunity to share this information with others. And so we will be posting this follow-up information on centralinaaging.org. All right, and we did just want to take a moment to thank our community partner, Healthy Aging NC. And they just provide a wealth of resources. It's a wonderful resource. We have their website listed here, and we'll be referring to some of their information shortly. So now a few words about our speaker. So we're very excited to have Dr. Dossie Brown with us today. And so Dr. Brown is with UNC Charlotte, the Assistant Professor of Gerontology and the Department of Public Health Sciences. So I'll share some information. Dr. Brown serves as an Assistant Professor at the University of North Carolina at Charlotte in the Department of Public Health Sciences. She is also affiliated with the Interdisciplinary Program in Gerontology and Department of Sociology at Charlotte, and works with the Motivated Cognition and Aging Brain Lab, McCabe Lab, also known as, at Duke University, which how cool is that, right? Her teaching efforts at Charlotte are focused on health and aging among all populations, which is what makes her such a great speaker for today's session. Her research interests lie in aging and motivation to exercise using mixed methodologies. Dr. Brown currently uses her knowledge in sociological and psychological motivation and physical exercise to conduct individual research. She assists in the McCabe Lab research studies through learning how to recognize neuroscience processes related to motivation and the methodological skills that will enhance her neuroscience research repertoire. So we are very excited. So thank you for joining us today. And we're going to turn the floor over to you.
All right, thank you, Katie. Good morning, everyone, and thank you for coming. Katie, I'm going to ask if you could put the presentation in presentation mode so it'll be bigger so everybody can see everything, I guess, on there. If you click on the lower right hand.
I'm sorry, somehow there was a timer set on that seemed to be auto forwarding it. I just want to make sure that it's not doing that anymore. Okay, here we go.
Perfect. All right. So today I'm going to be talking to you about understanding health disparities in older adults. As Katie had said, I'm a gerontologist. I love older adults. I love working with older adults. I love talking about older adults. I love exercising with older adults. And I picked this particular picture actually from the PowerPoint, because of how intricate it is actually. And I think about how our lives are, how the lives of older adults are, and how much goes into being an older adult, right? We sometimes see an older adult just as they are, but we don't think about where they've come from and all of the different things that go into who they have become for that day, or for that particular day that you see them. So that's kind of why I chose this picture, and I really liked it. So we're going to go to the next slide. Thank you. So today, the question is, what are health disparities, right? And the National Institute on Aging, I really do like this quote that they have talking about the differences, because that is what a health disparity is being able to actually recognize what the differences are in any health factor, right? Any health related factor. And when we're talking about health, we're talking about the total health, whether we're saying wellness, we're talking about disease burden, diagnosis, the response to treatment, the quality of life, everything that goes into a person's total health, and being able to recognize the differences in between their total health compared to what somebody else's health might look like. The overall cost of disparities is estimated to be about 1.24 trillion US dollars. And additionally, the U.S. Department of Office Management and Budget has classified minority groups, well, what we call minority groups here in the United States, but I like to call them the global majority. In the United States, we're talking about Blacks, Asian Americans, Pacific Islanders, Native Americans, and Hispanics. I want us to be able to recognize that even though we might call them minority here, when we think about the world and the global world, they're actually a global majority. And so that's going to be the focus of who I'm talking about today. Next slide. So the social determinants of health include healthcare access, education access and equity, social and community context, economic stability, and the neighborhood environment. These are all conditions in which people live, they learn, they work, and they play. And this all affects their health risks and outcomes. And together, they account for about 50 to 60% of health outcomes and are the key contributors to health and healthcare disparities. Now, when we look at this list, right, and we consider this list, we are able to think about the distinct significant differences in the people that we interact with based on their race, ethnicity, socioeconomic status. I don't have age on here because the age that we're mainly talking about today are people who are 50 and older or 65 and older, right? But that is also a factor associated with health disparities. So when we think about older adults, we're able to see these differences, right? And the outcomes of older adults based on many of these factors. And we also want to consider the potential disparity within the different populations of people when we come in contact with them on a day-to-day basis. We'll go to the next slide. So according to the National Council on Aging, high blood pressure or hypertension is the most known chronic condition for adults 65 and older. It is often caused by other conditions, other chronic conditions that we actually see listed here, including diabetes and high cholesterol. And when we consider the disparity of hypertension, however, it's been well established that African Americans have a higher risk of hypertension compared to other racial or ethnic groups here in the United States. The authors of the 2020 Jackson Heart Study published in Hypertension that high stress from a lifetime of discrimination was also associated with higher hypertension risk. So we saw on the slide a couple slides ago the different factors that have to do with the potential for health disparities. And it wasn't until the 2020 study that stress induced from a lifetime of discrimination was also something that needed to be considered as a factor for a potential disparity. And if you think about the population of people that you come in contact with and that you're working with, and you think about their lifetime and what they potentially went through, you have to consider that there are going to be some type of health risk factors that they've had to battle against their entire lives and potentially will have a direct effect on whether or not they have hypertension, diabetes, cardiovascular disease, kidney disease, all of these things, okay? So we'll go to the next slide. And we're going to dive a little bit more into health disparities. So first, we'll start with Alzheimer's disease. And I decided I'd start with Alzheimer's disease because this is something that we all have pretty much heard of. The government is doing a lot now to increase the funding so we can learn more about Alzheimer's disease. And I wanted to focus on it because of the research in itself. Man, I'm a researcher, so I'm kind of biased, right? But Alzheimer's disease is the most common form of dementia, and current estimates that are out say about 5.8 million people in the United States have Alzheimer's disease and related dementias. Of those 5.8 million people, 5.6 million are 65 and older. And there are various risk factors to Alzheimer's disease, but the one I'm going to focus on today for a little bit is genetics research. So by 2060, the number of Alzheimer's disease cases is predicted to rise to an estimated 14 million. So we're going from 5.8 million to 14 million by 2060. And people with cases who identify as being Hispanic is set to increase 7 times over today's estimates. And those who identify as Black or African American are set to increase 4 times over today's estimates. So we have a lot of people who are part of the global majority that are going to be diagnosed with Alzheimer's disease over the next 30, 40 years. However, there have been varying reports from research which are not consistent as to understanding the ApoE4 allele, which may be associated with increased risk to having the disease. And the reason for this is the majority of research that's been done on Alzheimer's disease has been done on whites. There is more research that is being done that includes people who are Black or African American, Hispanic, American Indian. However, there isn't enough research, right? So we've got these different varying reports that say, oh, well, yeah, this population, if they have the ApoE4 allele, they're definitely gonna, get Alzheimer's. And then we have other reports that say, no, that's not necessarily true. And so there was one study that actually analyzed the effect of the allele in individuals from 6 different Latino backgrounds. They included Cuban, Central American, Dominican, Mexican, Puerto Rican, and South American. And that, looking at those 6 different Latino backgrounds, it was suggested that factors related to geographic background and genetic history may actually alter the extent as to whether or not the ApoE4 actually contributes to cognitive decline and thus having a form of dementia or having Alzheimer's disease. We also have to consider the modifiable risk factors that may also increase the risk of Alzheimer's disease. And we've got those listed here, right? So we've got physical activity, we've got education, staying socially and mentally active. But the problem with knowing these modifiable risk factors without having the proper research to support these modifiable risk factors and understanding that if everyone is able to be physically active and everyone has the same type of education and it's equitable, right? We don't know whether or not that will have an effect on everybody. And so it's extremely important that the government continues to support research on understanding Alzheimer's disease in global majority persons. That way we can actually fight the disease and beat it for every adult, not just a certain number of people. When we look at diabetes, we have 11.3% of the total population that has diabetes, right? 26.4 million adults who are 65 and older have pre-diabetes. So they're just on the cusp of being, of saying, hey, you got diabetes, we've got to do something about that. So some risk factors to having diabetes includes, again, inactivity or not being physically active, right? We've got blood lipid levels, which are high. We've got age, we've got weight, we've got fat distribution of that weight, and we've also got family history. So along with the other global majority populations, we see that Pacific Islanders and American Indians have the highest rates of diabetes among the 5 racial groups at 14.5%. People who have less than a high school education and adults with a family income level that is below the poverty level line also have the highest rates of diabetes. So we go back to, the first couple of slides where we see the importance of these social determinants of health, right? If you are not able to get the education that you need, right? If you, in getting education, that's going to have a direct effect on understanding what you need to eat, understanding how much you need to exercise, and considering our older adults now, right, who are 70 and 80 years old, they weren't afforded the same type of opportunities, 40, 50 years ago to education as even I am today, or my kids will be, or my grandkids, right? And so my thought process is, okay, we do what we can right now for the population that we have, and we do what we can for the people who are coming up in order to make things better for everyone, right? So rates can also vary by ethnicity too. So we see Asian Indians are 2 to 3 times as likely to get diabetes as Korean Americans, right? And Pacific Islanders and American Indians are more than twice than likely to have a condition as whites, who have about an 8% chance as having it when they're adults. So the health disparity itself, just diabetes, is not just because of family history. There's so much more that goes into it. But if we are thinking about these modifiable risk factors, what can we do to help people? Education is the number one place to start, in my opinion, right? Because with education, you learn about everything else in order to be able to give your body the chance to fight against all these different types of chronic conditions, or to at least make your life a little bit better if you are living with those chronic conditions. All right, we'll go to the next slide. All right, going on to cardiovascular disease, right? So cardiovascular disease is listed as the number one underlying cause of death, and it has accounted for 874,613 deaths in the United States in 2019. Now, those were the latest statistics. Of course, because of COVID-19, we're kind of still waiting on what's going to happen with 2020, 2021. But it's going to be skewed, probably because anybody who was diagnosed with COVID-19 and they died, they automatically got put under as the cause of death being COVID-19, even if they had some type of cardiovascular disease before they got sick. So it's going to be very different to see what's going to happen over these next couple of years. But approximately every 40 seconds, someone in the United States will have a heart attack. Every 40 seconds. That's a lot of people. And on average in 2019, someone died of a stroke every 3 minutes and 30 seconds in the United States. So we see cardiovascular disease and the direct effect that it has on people, right? And based on 2015 to 2018 data, an estimate number of 126.9 million American adults had one or more type of cardiovascular disease. So that includes coronary heart disease, heart failure, stroke, hypertension. And men generally develop cardiovascular disease at a younger age and have a higher risk of coronary heart disease than women do. But women, in contrast, are at a higher risk of having stroke. And that usually occurs at an older age. And we have to also think about the fact that women tend to outlive men longer, right? So they're at higher risk for stroke because they're going to live longer, right? So it's something that we have to think about with, cardiovascular disease. And then also understanding that Black persons or African Americans are most likely to develop cardiovascular disease over any of the populations. When we look at kidney disease, right? Kidney disease is not, I think, given the due respect that it actually deserves, honestly, as a chronic condition. We hear a lot about the other ones that I've talked about, but kidney disease is extremely important to understand. And although Black or African Americans only make up 13.5% of our total US population, they also make up 35% of dialysis patients, right? And so the major causes of kidney disease include diabetes, right? Hypertension and cardiovascular disease, right? So it's like all of these things come together. If you've got one, there's a good likelihood you're going to get the other. But all of this is going to be more prevalent in Black Americans. So the disparity that comes in with Black Americans often is the kidney transplant or having some type of optimal treatment for kidney failure. Black patients face barriers to access at every step of the process, and their average wait for a kidney transplant is a year longer than white patients. Black patients are also less likely to receive the transplant evaluation. They have less access to the wait list. They spend longer time on the transplant wait list and are less likely to survive that wait list. And they also have a lower rates of graft survival post-transplant. So we have to think about how a disparity can not only have an effect on a person's health, right? We also have to think about how does this disparity then affect this health when they are going through the healthcare system, when they're trying to do what they can to be more healthy. A lot of times, hospitals are not aware of their own biases that come with working with certain populations. A lot of times people are not even aware of their own ageist views. So it might not even have anything to do with your racial or ethnic makeup. It might start with the fact that, oh, here comes somebody and they've got wrinkles, right? And which is absolutely absurd, but it happens. And then you have these automatic views of who this person is, how they live their life, have they taken care of themselves? And all of these biases then have a direct effect on how the person is going to receive treatment. And this becomes a disparity, right? We'll go to the next slide. All right, now we're going to talk about older adults in North Carolina. All right, we'll go to the next slide. Thanks, Katie. All right, so we have 100 counties in North Carolina, and 82 counties in the state had more than 60, had people that were 60 and older, more than they are 18 years or younger. And by 2025, that number is expected to increase to 89 counties, and by 2038 to 95 counties. So our state is getting older, right? We have people who have migrated from other states for various reasons, including the great tax breaks for older adults, right? There's no tax on Social Security income, and income taxes have been lowered at a flat rate, and that rate keeps decreasing. So there's no state-to-state tax, low, corporate income tax. And that, and that only really matters to the people who can afford to make the move in the first place, right? But we do have people who are migrating here, and that's having a direct effect on the number of older people that we have in the state. Additionally, North Carolina has a lower cost of living than the national average, right? So we've got housing, utilities, and transportation costs that fall below the national average, and groceries and healthcare still, even though we might think they're high, they still are slightly lower, or excuse me, they're just a little bit above national average. And so when you average out, the cost of living as far as having healthcare in your groceries compared to housing and utilities and even buying land, right? North Carolina is in a pretty good space. And so overall, the cost of living is 5 points below the national average. However, that's for people who are in the average income or above average income. We're not talking about those who are living in areas where they can barely even afford their housing or utilities. And so when we think about the people who are aging, right, and what aging looks like in the state, we have to be more prepared for this population who's aging to be able to address the needs of those who might be migrating here and they can afford to, but we also have to consider those who are just barely making it by in order to be able to survive. All right, we'll go to the next slide. So For this next part, I'm going to focus on 2 of the 4 North Carolina State Plan on Aging goals through 2023, right? With respect to how they intertwine with health disparities and how we can help in the efforts to achieve these goals. Now, I'm going to guess that, these goals are going to have to be renewed because I have a feeling that everybody was kind of put on hold over the last couple of years, and it's very difficult to be able to reach certain goals if you can't reach people. And COVID-19 kind of put a halt on that for us to be able to reach people the way that we wanted to. All right. So on the next slide, for focus number 1, we're focus number 1 is support adults of all backgrounds and their support systems with access to information, allowing informed choices that support them at home and in the community. It's a mouthful. I'm going to say it again. The focus number 1 is to support older adults of all backgrounds and their support systems with access to information, allowing informed choices that support them at home and in the community. And when we consider what all backgrounds look like for North Carolina state residents, we have to consider gender, race, ethnicity, environment, so their place of residence, whether they're urban or they're rural, social and economic characteristics, and their health statuses. All right. So women, right, with the higher life expectancy than men are more likely to live alone and face more challenges as they age. Women and men, owing to their biological differences and gender roles, have different needs, challenges, and opportunities which contribute to different life and health experiences. According to the Williams Institute, North Carolina is home to about 250,000 lesbian, gay, bisexual, and transgender adults. And many experience discriminations because of their sexual orientations and gender identities. Many older adults who were unable to live their lives as they saw themselves now have worse mental and physical health compared to heterosexual or cisgender older adults. LGBT older adults have higher risks of mental health issues, disability, and higher rates of disease and physical limitations than their heterosexual counterparts. Compared to their cisgender peers, transgender older adults also face a higher risk for poor physical health, disability, and depressive symptoms, many of which are associated with the experience of victimization and stigma. So we have to be considerate of the fact that our world is changing and people are living their lives that they want, the way that they want to, right? Whereas maybe in the 60s and the 50s, they weren't able to. And so that's why for me, for this particular slide, I wanted to focus on the LGBTQ population. We're learning that studies find that older adults who identify with LGBT have higher prevalence of engaging in risky health behavior, such as smoking, excessive alcohol consumption, and risky sexual behavior compared to non-LGBT adults. However, LGBT older adults have higher rates of HIV testing than non-LGBT seniors. And the reason why this is important to understand is because there is a higher number of adults who are living in communities who are diagnosed with I'll say sexual issues is the way I'll say it, because it goes undiagnosed, right? So they are living their lives the way that they want to, but they're not being safe in the process. And so the things that heterosexuals could learn from people who are in the LGBTQ community is that, getting tested is actually a good thing, and it makes life more safe for you and the people that you're surrounded with. Among LGBT older adults, HIV positive LGBT elders have worse overall mental and physical health, disability, and poorer health outcomes, and higher likelihood experiencing stressors, as well as barriers to care. And that is what is extremely important, is the barriers to healthcare that the population experiences. And there are people who are trying to change this, and legislation that is trying to go through to let people recognize that family is family, right? And if I need this person to stand and vouch for me, and they are the person who is going to talk for me if I'm not able to talk, then it should not matter whether or not we're related by blood, so to speak. As providers of older adults, it's important that we recognize how people want to be identified and to respect that. When we meet people who do not identify as cisgender, or they are not heterosexual, right? It shouldn't matter, right? We have to remember that humans are humans, people are people, and we all have feelings. We all want respect, and we all deserve it. We'll go to the next slide. All right, so of all the North Carolinians aged 60 and older, approximately 21%, as members of the global majority group, demonstrate that North Carolina's ethnic and racial diversity is increasing. And while we have seen this growth on television, it's not as often that we consider that the people that we may come in contact with also identify with being immigrants and or refugees from other countries. We cannot always assume that we know a person's racial or ethnic makeup. So instead of making assumptions, the best thing to do is just ask in kindness. And you do so once you've established some type of a relationship. So you can do this without potentially offending them. Consider this. North Carolina has the largest population of Montagnards, right? Perhaps 10,000 living in the US. These people are refugees from the Central Highlands of Vietnam, and they first came over in 1986 as former fighters that were allied with the US Special Forces during the Vietnam War. Today, most of the population lives in Greensboro and in Charlotte. So if you're working in Mecklenburg or Guilford counties, you may work with someone who identifies as Montagnard, but it's important for you to know how they identify, right? So asking, where did you grow up, may not always give you the answer you're looking for, because if a person grew up in New York, but immigrated from another country as a kid, they'll probably just leave the question answer right there. Getting to know an older adult will more often than not grant you the understanding that they moved here with their parents from another country, or through conversation, you may learn about customs that they continued in New York from where their family had originally hailed. Never ask, what are you? Because you may get a smart answer like human, which most older adults feel they have every right to say since they lived for so and so many years. At the right time, you may be able to ask, what is your ethnicity? Be prepared to listen. Be prepared to recognize the custom of older adults who may want to share these things with you. And when you do learn, make a conscious effort to recognize when they celebrate their religious holidays, their country's Independence Day, or when you hear some news about their home country. We'll go to the next slide. So here are some action steps for focus number one. Which was supporting older adults of all backgrounds and their support systems with access to information, allowing informed choices that support them in their home and the community, right? So as providers to older adults, it's important that we recognize how people want to be identified and respect that. When we meet people who do not identify as cisgender, meaning or denoting related to a person of some, of personal identity and gender that corresponds with their birth sex, or heterosexual, we remember they're human. They have feelings. They want respect. We should give that to them. We should look at customs and know how you can support people in their customs. We recognize they want to be identified. We respect identity. We remember that they are people too. We learn where people are from. We listen to their stories. We look at their customs, all right? We'll go to the next slide. All right, focus number two. Focus number two is to lead efforts to strengthen the whole person care by engaging multiple community partners to increase and leverage resources. I'll say that again. Focus number 2 is to lead efforts to strengthen whole person care by engaging multiple community partners to increase and leverage resources. Go to the next slide. Right now, we're going to take a break and we're going to have a quick poll to find out where you actually work with older adults. So I'm going to ask that you just take a minute, please, to answer the poll question. If you have an additional place that is not listed here, I'm going to ask that you put it in the chat and we'll have Katie mention those afterwards.
Looks like responses are still coming in. I'll give it just another few moments here. All right, looks like we've heard from everyone. I can share these results. So it looks like we've got some caregivers represented here today, CNAs, fitness and wellness instructors. We have some individuals representing geriatricians or gerontologists, some home health or personal care aides. We have RNs or LPNs or LVNs, therapists, patient advocates, social workers, and then we have the other category. So I know Dr. Brown invited folks to go ahead, and if you fall into that other category, do share that with us in the chat box and I'll take a look there. Let's see here. I see some social workers, senior center. I'm an advocate for older parents, senior law attorney, SSA, so Social Security Administration, aging service specialist, community health worker, some representatives from the Area Agency on Aging, the City of Charlotte, again, more senior centers, Social Services Administration, a community advisory committee member, representing an MCO, Archwell Health, primary care, a shelter social worker, DSS, ECA. So we've got lots of representation from those serving older adults and those who volunteer also for an assisted living. And here's someone, they're still coming in, someone who designs environments for people, particularly greenways. And it looks like some more representatives from Area Agencies on Aging, the Parkinson Association of the Carolinas, and also Adult Day Health.
We've got an array of people here. That's awesome. So in consideration of where we're all coming from, right, we also need to consider the environments of where our older people are living, right? And we consider the environments of where we're working with our people. In consideration of health disparities that we find among people, we should be recognizing that a high proportion of our older adults are actually living in rural counties rather than living in what we consider urban counties, right? And so we have more rural spaces in North Carolina than we do urban spaces. And within those rural counties, they're also linked to a lower median household income, a lower level of education, higher rates of poverty and disabilities. Now, we'll see this more when we look at different racial and ethnic groups, but I think that it's also important to understand that it does not always affect just people who are part of the global majority. We have a high number of white Americans who are also living in rural counties that have health disparities because of the fact that they are that they have a lower level of education, higher rates of poverty, and also disabilities. So while 80.2% of adults who are 60 and older live and own their own homes, the location of where those homes are at makes a difference. For older adults who reside in rural areas, they're going to face unique challenges within their living environment, such as lack of transportation options, access to health care, isolation, higher poverty, and mortality rates. So how can we be more proactive in helping to dismantle disparities for people who are living in rural counties? So we'll go to the next slide. We do this by coming together and working together, right? So it's estimated that about 466,600 caregivers provided 531 million hours of unpaid care in 2018 in North Carolina. I can only imagine what that number was between 2020 and 2022 at the height of the pandemic. We have caregivers who are very diverse and have unique needs based on their own strengths and challenges. And having a network of persons within a community that can support caregivers so they may continue to assist their patients or their family members and do so without expending their own mental and physical health is something that we all need to focus on a little bit more. When we consider the accessibility for people who are living in the rural areas, it's important that we can establish partnerships with transportation services such as taxis. So it's easier for the people to be able to get to seeing their healthcare provider. I especially think of the veterans who I've worked with and how long it takes them to have to travel an hour to just to come to the Durham VA, right, to be able to see a healthcare provider because they're not able to get the type of services that they need within their own community. It's important that we also be able to contract with bus services or hire drivers. Working with community partners such as nursing homes, right? When conducting community needs assessments, one of the things that we need to do in order to be able to come together is actually understand what our community needs in the first place, not just to have these assumptions of, well, I see that this is a problem, so I'm going to go ahead and just try to solve it. Well, what you might see as a problem, somebody else might not. The people in the community might see a bigger problem, or they might understand what the underlying issue is that is causing the problem. But without being able to do some type of needs assessment and to understand and to talk to people, actually not going to work, right? So we want to leverage also other groups like paramedics, other community health workers, the people who are going to come in contact on a regular basis with our older adults are the people that we should be working with. Within healthcare, right, providers should consider hiring additional non-physician providers into their practice, as well as supporting non-physicians in maximizing their scope of practice by supporting clinicians such as nurse practitioners, physician assistants to practice practice at the top of their license. Practices may be able to increase the number of available appointments. So this is, some of the things that I think about. All right, so let's go to the next slide for the action steps for focus number 2, which was to lead efforts to strengthen the whole person care by engaging multiple community partners to increase and leverage resources, right? So you want to get to know your designated area. You're going to embrace your community. And one way to do this is to capture the data, the demographics of who you're currently serving, the demographics of those you want to serve, and ask yourself the following questions as you're doing this. Is it reflective of your community? Are you missing any populations, particularly at most those at needs populations? What can they do to increase the outreach and service of those who are most in need? The last question is so important because it asks the question to the people that you are serving, right? You cannot embrace your community if you don't know your community. You can't engage with people if you don't know who those people are. And you certainly can't empower the environment if you don't do the first 2, all right? Next slide. So as I'm finishing up here, wanted to give you a resource. Healthy Aging North Carolina developed a 6-page resource page with information to support creating diverse and inclusive evidence-based program environments in all communities across North Carolina. And Kristen has gone ahead and she's put the URL as to where you could find that. It's also here in the recording for those people who are watching this afterwards. And so, go to this resource page. There's a lot of information on there that can help you out if you're looking to, increase the number of people that you are reaching and at the same time helping to decrease the disparities that we have in North Carolina. Slide 23 are the references where I got a lot of information that was presented that I found, and you're more than welcome to, use these and go to them afterwards. With the next slide, I would like to thank Centralina and especially Katie, Kristen, and Margaret for all of their help for pulling this together and helping me to get my life in order so I can actually do it. And with the last slide, I'm just going to ask if there are any questions.
Wow, wonderful, Dr. Brown. Thank you so much. At this point, let me see. We did have a question which was answered in the chat of how to go about volunteering and helping with older adults. So we dropped in the North Carolina Area Agency on Aging link. Another question came up, and this is when you were talking about the rural counties. The question reads, for the 100 counties, are those figures the smallest percentages for seniors or for those demographics races? And I'm not quite sure. Maybe Kimberly, if you want to maybe clarify that a little bit. You were talking, as I recall, you were talking about their percentages of demographics in the and I thought it was rural counties, and I think that was kind of being thought over for all of the counties.
No, so I was talking about the rural counties in North Carolina. If I'm not mistaken, I think there's a large number. I want to say it's like at least 80 counties that are actually considered rural in North Carolina. And the number of people that we have that are 60 and older they're going to have more in the rural areas than we actually have living in the non-rural. So let me look this up. Let's see.
So Kimberly said, I was asking if those percentages were for Black seniors or just Blacks.
Oh, for the percentage. Oh, that's a good question. Katie, can you go back to that slide?
Let me know when I get there.
I think we're at slide 16. Maybe.
Is it this one related to across the state?
I think so.
Okay.
Oh, wait, no, go forward. That's the plans. I think she's talking about this. Is this the correct one?
I'm not sure. The question came in when you were at the slide.
Oh, she said, no, this is not the slide, the rural slide.
Yeah, when you were talking about the rural communities. And I remember the Robeson was mostly Black. And forgive me for.
Oh, there we go.
Yeah.
Okay, so this one is actually talking about the total number of people who are Black. And of course, that means that the number of older Black Americans that are living in those rural counties is going to be even smaller. You're welcome.
Another question, let me see. Gwen wants to know what amount of seniors exercise more if the facility is near their home versus a YMCA, YWCA, rural versus urban?
You know, that's a very good question. I don't know the answer to that question off the top of my head, but I will tell you that for the number of people who are older that live in a community, like, so if you live in a community that has like a gym, you're more likely to exercise because you don't have to have the access to transportation to get to a certain place. And so, and that's why we talk about being able to come together and to have stuff like transportation, because a lot of older adults who might have worked out in their entire life, but they're not living in a space where they have a home gym, or they are not in an assisted living facility that has a home gym, aren't able to get to a gym. And the other consideration, of course, is that a lot of people, you know, they work out at home now, right? And there are ways to be able to do that. And YouTube has so much now, right? Even my grandmother, who's 88 now, will use YouTube as opposed to going out to the gym sometimes just because she doesn't feel like it. She can, but she doesn't want to. So yeah, if there's transportation is better, but if you live in a nearby facility, one is twice as likely to use the facility. Thank you, Zoe.
Yeah, great. Another question, how can we get kids more engaged? Our younger generation is living for the present, but they will eventually become older and need all of this information.
You know, the way that you get kids involved is to get involved yourself, and you encourage them to come with you. That's the only way that I've been able to get my kids involved. My kids have no, they don't have a gerontological bone in their body whatsoever. My oldest wants to go to school for elementary education, you know, but that is how we do it, right? So I remember it was years ago. I don't know what they were doing, but we were in the kitchen one day and my son made a joke and he started walking around as if he had a cane. And he was like, look, I'm an old man. And I was like, what? Is that what you think all old people are like? And I immediately signed all of us up to go to the senior games and to volunteer, because I was like, you guys are not going to grow up thinking that all older people are in wheelchairs and all they can do is, you know, just sit around. I said, that's not what older age looks like. It's not what it has to look like. And so I really believe that the way that you get kids involved is to actually have them around older adults, right? And to let them understand that being older is just a part of life. It's better than the alternative. And it can actually be fun being old, you know, being around older adults.
Yes, and Carol brought up the point of, thank you, Dr. Brown, of using, if their insurance is accepted at the gym, or if a facility would accept their insurance.
Yeah. Yeah, that's something to look into. Somebody else had wrote about Silver Sneakers, which is also a great program, you know, for older adults. You know, there's, again, a lot of it has to do with information and education and knowing what's out there and that's available to you, and not recognizing or not just thinking that I have to pay so much, you know, to be a part of this gym, you know. So
right.
Yeah.
Great. You also mentioned for the intergenerational, I think, yeah, intergenerational activities, and also tons of wonderful presentation. Love this presentation. Lots of great information.
I appreciate it. I appreciate it. No, this was good. This was good.
Katie?
Well, wonderful. So I think that wraps up all of the questions. Please join us again in thanking Dr. Brown. Thank you so much for sharing your expertise with us. This was wonderful. Again, just some reminders. So we will be sending out some information to all of you who have attended today. It will have the link to this webinar, which will be shared on our website. We'll also have that link to that resource as well that was mentioned. So you'll be able to reference that after the fact. So thank you so much. And then lastly, we do just want to kind of have you save the date. We do have another webinar coming up next week. So that will be Age My Way, federal and state advocacy updates. So that's May 11th from 10 to 11:30. I believe Kristen's going to pop in the chat box the link. If you've not yet registered for that webinar, we'd love to have you there. We'll have Bob Blancato, who will be sharing information that's relevant across the nation. And then we have Heather Burkhart, who will be sharing advocacy updates specific to North Carolina. So that being said, everyone, thank you so much for joining us today, and we hope you enjoyed the webinar. Have a great day, everyone. Thank you so much. And thanks again to Dr. Brown.
Thank you.